Hi everyone, my name's Karim Ladak. I'm a rheumatologist, like Joe said, from Canada, but I did my training at Cornell and it's always nice to be back stateside. So, when Joe and I were talking, we sort of brainstormed ideas for this session. We thought maybe cutaneous lupus, maybe dermatomyositis, maybe JAK inhibitor toxicity, because it was in the rheumatology world where we learned about the potential safety issues with JAKs. But I thought that was too much to cram into 20 minutes to do any of it well. And so I hope you don't mind. Today we're going to be focusing on cutaneous lupus. Okay, we've all heard of lupus, yes? Anybody not heard of lupus? So everyone has heard of lupus. This is a systemic autoimmune disease that primarily affects women of childbearing age. It can affect pretty much any organ system in your body. CNS, lungs, it can fry your kidneys, put you on dialysis, give you chronic inflammatory arthritis, and very frequently, it can affect your skin. We call that skin involvement cutaneous lupus. Now, you can have cutaneous lupus in isolation, or you can have cutaneous lupus as part of the systemic process. I see a lot of nods, which is great. We subdivide cutaneous lupus into three categories: acute, subacute, and chronic cutaneous lupus. These three subcategories are united by the fact that these are photosensitive lesions, that when you biopsy them, they show a specific finding called interface dermatitis that the pathologist can recognize, and that they can occur in patients with systemic lupus. The three subtypes are acute, subacute, and chronic cutaneous, and we're going to get into each of those. Okay, so who gets cutaneous lupus? Whether it's the isolated form or the systemic form, so part of SLE, cutaneous lupus is primarily a disease that occurs in young women of childbearing age. So young women of childbearing age. Again, whether that's the isolated form, the cutaneous isolated, or as part of SLE. And it tends to be more prevalent and more severe in women of color. Okay, everyone with me so far? Yes, some nods? Good, making sense? Perfect. Okay, I said that cutaneous lupus can occur in isolation, and I said it can occur as part of the umbrella of SLE. So what is that link? What's that relationship? Because when you've diagnosed cutaneous lupus in your clinic, your patient's going to want to know, that young female is going to want to know, does this mean I have lupus? Does this mean I might lose my kidneys and end up on dialysis? Does this mean I might have to go on disability because of chronic joint pain? And you can immediately reassure her. Usually it's a her. There's a small number of men who also get lupus, but usually it's young females of childbearing age, like we said. And so you can reassure them that only 15%, 15% will go on to develop systemic disease. Usually it's a skin-limited condition. And of the ones that do progress to systemic disease, typically it's mild. But you can also offer an educated estimate of what their risk is based on two factors. Factor one is the subtype. Is it acute, is it subacute, or is it chronic cutaneous lupus? Acute has the highest risk. You can almost guarantee them that they will have SLE. Chronic, on the other hand, which is the most common, is the least likely. It only rarely develops into systemic SLE. And subacute sits somewhere in the middle. So based on the subtype, you can estimate their risk. The second way that you can estimate risk in an educated fashion is with blood work. You can check lupus labs, 3 tests, an ANA, a double-stranded DNA, and an anti-Smith, SM, anti-Smith. The more positive your labs, the more likely you are to progress into systemic disease, and the more negative your labs, the more likely you are to just remain cutaneous isolated. Yes? Make sense? Perfect. Okay, so acute, subacute, chronic, they all share similar features. Women of childbearing age, photosensitive, can exist in isolation or can exist with systemic disease. Let's break them down one by one, and we'll start with acute. When a non-medical individual, and some medical individuals, think of lupus, the rash that they're thinking of is the butterfly rash. That looks familiar to most people, I think, yeah? I'm seeing a lot of nods. It is in a malar distribution involving the cheeks, the bridge of the nose, and importantly sparing the nasolabial folds. And the way it heals is important. It heals without scarring, and it heals without any color changes. So between flares, you can't tell that that individual, for the most part, can't really tell that that individual ever had acute cutaneous lupus, that butterfly syndrome. It is, as I said earlier, almost always associated with systemic disease. You can almost guarantee if you see it, they will move on to SLE, systemic lupus. And so it would stand to reason when I tell you that almost all of these young women, some men, will have a positive ANA, which is a non-specific but quite a sensitive test for lupus. Most of them will have, almost all of them really will have a positive ANA, and many will also have a double-stranded DNA and an anti-Smith. Okay, acute, subacute. So, subacute lupus, similarly, is photosensitive, tends to happen in a photo-exposed distribution, but it looks different. It appears in one of two forms, either an annular appearance, raised kind of erythematous edges with a central clearing, or papulous squamous, looks kind of like psoriasis or eczema. It likes photo-exposed areas, upper shoulders, upper torso, upper arms, and the neck, but for some reason it tends to spare the face. Now you remember what I said earlier, if you have acute cutaneous lupus, how do the cheeks look between attacks? Do you remember? I'm pointing at you. Do you remember? Does it look normal? Yes, it does. It looks completely normal. There's no scarring and there's no discoloration. Good job. In this condition, in subacute though, there's no scarring between attacks, but there is depigmentation. So if you find old lesions, you'll see evidence of depigmentation. That's an important clue for you. The other important clue is that it tends to spare the face. Now, subacute lupus also has a unique serological profile. They tend to be ANA positive, and they tend to also have a positive anti-Rho in the majority of patients. In these individuals, with that seropositivity, you can guess that they are at risk of progressing to systemic lupus. About 50% of patients with subacute cutaneous will one day end up with SLE. But the good news, once again, you can reassure them that the majority of patients with this condition have mild disease, not severe disease. And one more thing I want to tell you about subcutaneous before we move on is that 1/3 of cases with subacute cutaneous lupus are drug-induced. We caused it with one of 100+ different classes of drugs. Antihypertensives, antifungals, even TNF inhibitors can do this to you. And it is indistinguishable from the wild type, from the sporadic form of subacute cutaneous lupus. Indistinguishable. The appearance, the biopsy, even the lab work, the ANA and the anti-Rho is indistinguishable. You might have one clue though. Do you remember we said lupus is a disease that is most commonly seen in which population? Young women, childbearing age, right? Drug-induced subacute cutaneous lupus, though, tends to be in men around 60. So that's one little tip. Typically, the culprit drug will have been started within the weeks to months preceding the new rash. And if you are suspicious and you catch that it is drug-induced and you stop that drug, within 3 months, there are no new lesions. Okay? Lastly, chronic. Acute, subacute, chronic. Chronic cutaneous makes up the lion's share of cutaneous lupus. It is the most common form of cutaneous lupus. It is also the most severe form of cutaneous lupus. Remember, we said acute between episodes. You rightfully said skin looks normal. Subacute, we said they can depigment, but they don't scar. Chronic. Chronic is the most severe. It can leave you with a scar, and it can leave you with dyspigmentation. Chronic cutaneous lupus has its own slightly unique distribution. It's also photosensitive. It loves photoexposed areas, neck, face, scalp, and uniquely, the bowl of the ears. And you can imagine this is quite a sensitive area. It's a visible area. And so the chronic changes that these individuals need to live with for the rest of their lives can be devastating. The appearance of chronic cutaneous lupus is usually discoid. Again, the most common form, usually discoid. It is a coin-shaped, raised, slightly scaly erythematous appearance. And it leaves, like I said, you can see it right here very nicely, a scar, and hypopigmentation or dyspigmentation. Again, most common in women of reproductive age. Again, when you biopsy, the pathologist will see interface dermatitis. But the good news is that even though this is the most severe form of cutaneous lupus, even though it's the most common form of cutaneous lupus, if I had to pick one type, this is the one I'd pick, because it almost never turns into, I shouldn't say that, in 90% of cases, it will not turn into SLE or systemic disease. That makes sense? Acute, you can almost guarantee they're going to have SLE. Subacute, let's say a 50% chance, and it's going to be super mild when it happens. Chronic discoid, 90% they're going to be fine. When you treat it like I know you guys absolutely can, when you treat it well, it's a non-issue. Okay, that was a lot of information. Acute, subacute, chronic. They are united by the fact that they're photosensitive. They're united by the fact that you frequently see interface dermatitis when you do a biopsy. They're united by the fact that they primarily occur in women of childbearing age, with the exception of subacute drug-induced, which usually happens in older guys. And they're united by the fact that they can be seen to varying extents in SLE as opposed to just isolated cutaneous disease. But there are differences as well in terms of their appearance, the butterfly rash versus annular versus a discoid appearance. They are different in terms of their distribution, head and neck, with particular sort of predilection for affecting the scalp or the ears, like chronic, or subacute, sparing the face, or the butterfly distribution, the malar distribution. They are unique in terms of how they heal. Acute, no depigmentation, no scarring. Subacute, depigmentation, no scarring. Chronic, scarring and depigmentation. And they vary in terms of how much they are going to turn from cutaneous, isolated, into SLE. Acute, guaranteed. Subacute, 50%. Usually if they do, it's mild. Chronic, the beauty is, even though it's the most severe skin form, they will only occasionally, about 10% of cases, turn into SLE. This is a table not for you to memorize right now. It's only if, at rheumatology conferences, we take a lot of pictures of slides. It's only if you want to take a picture and reference it later if you have a case like this. Okay. So management. Non-pharmacologic first. I know it doesn't sound very important because all we want to learn about is drugs nowadays, but non-pharmacologic is super important in lupus. This is a photosensitive condition. So if you photoprotect, which you guys know how to do much better than we do in rheumatology, you're doing them a favor. I say something silly like, use high SPF sunscreen and like that UV protective clothing stuff that dermatologists talk about. And then I send them down the hall to my colleague who's a dermatologist 2 doors down. But photoprotection is essential. These are photosensitive lesions, number 1. Number 2, smoking cessation. We find a lot of patients with active cutaneous lupus are smokers. If you get them off their cigarettes or help support them to quit, the level of disease activity will fall as well. And the third non-pharmacologic intervention that applies to everybody with cutaneous lupus is vitamin D supplementation. There was one trial from 2014 in Spain. It was a small study that looked at individuals with cutaneous lupus who were vitamin D deficient. They randomized them, 2 small groups randomized them to repletion or no repletion. And what they found was that when they repleted the vitamin D level, it helped control the immune system better, which makes sense. If you look at other fields in medicine, like neurology, multiple sclerosis, and vitamin D deficiency, for example, we know that if you get the vitamin D levels back up to the normal range, the immune system behaves better. Okay? So, photoprotection is penultimate. Smoking cessation, you're doing them a huge favor. Get their vitamin D levels up as well. And then you remember we said 1/3 of cases of subacute cutaneous lupus indistinguishable from wild type, other than maybe the demographic being older dudes. If you identify that it's drug-induced, you stop that medication. Within 3 months, you should see no new lesions. Okay, now we get into drugs. The easiest way to think about this, about inflammation, at least from a rheumatology perspective, is that we have active disease, we have the fire, we need to put it out. We need something that's going to lift uphill. And typically that's corticosteroids for us. and then you need a maintainer. So when the inflammation's live, you want to quash it, and when it's quashed and quelled, you want to keep it asleep and dormant. To quash your inflammation in the acute phase, to get the active disease under control, use steroids. If it's a limited bit of skin disease that's localized and not too bad, topical is fine. When you use topical steroids, we're talking potent topical steroids. And remember, a lot of these are on the face. So in the rheumatology world, we've always been taught, you need to be really careful about, or in the internal medicine world really, we've been taught you got to be really careful about potent steroids on the face because it can lead to skin atrophy. You guys are probably a little bit more cavalier than we are in the non-dermatology world, but this is what we're taught because it can lead to skin atrophy. However, we still use potent steroids in these individuals for 2 weeks to get the disease under control. Because remember, if we're talking chronic cutaneous lupus, we are talking about a disease that will leave scarring and discoloration, scarring alopecia for the rest of their lives. We get it under control, we hit it hard up front, and we get it under control, and then we move on. Now, that's limited disease. Localized, topical. If it's anything more than a little bit of localized or limited disease, systemic steroids. Prednisone's a great option. 0.5 to 1 milligram per kg per day works really well. And you taper that over 4 weeks. 90+% of patients will respond to that beautifully. Okay, you put out your fire, how do you maintain? If it's localized or limited, you can go topical. You can use tacrolimus, a topical calcineurin inhibitor, or you can use a low potency steroid, topically, low potency. Alternatively, we in rheumatology love, in the lupus world, I'm going to say this one more time, we love Plaquenil, hydroxychloroquine. This is an anti-malarial that at some point we kind of discovered, hey, it works really well, really well in lupus. And yet the side effect profile is incredible. It's a really gentle drug, and yet it works beautifully. It doesn't just calm down active manifestations, it prevents some of those severe manifestations we talked about earlier in the SLE world, frying kidneys from severe nephritis leading to dialysis, CNS involvement, encephalitis leading to seizures, bad joint disease, things like that. It works so well. In the rheumatology world, we think of Plaquenil or hydroxychloroquine as a lupus vitamin to be taken every day. The dosing is important. 5 milligrams per kg up to 400 milligrams PO daily. So let's take an example. You have a young female of childbearing age who has a little bit more than just localized disease. You've quashed her disease with prednisone, and now it's time to start a maintainer. She's 60 kilos, 60 times 5 milligrams per kg is 300 milligrams PO daily. That's 1.5 tablets to be taken every day, and that will do a beautiful job of keeping the majority of individuals with this condition nicely controlled. Okay? 3 side effects you should know about. 1, headaches, uncommon, usually mild. 2, GI upset, uncommon, usually mild. 3, a tan. But not a nice tan, that's a euphemism. That's what I tell my patients. It is a gray tan. It is a gray tan that's not that attractive, usually sits in the front of the shins in about 7% of patients who've been on this drug for years, and it can also tan the back of the eye. And the problem is when it tans the back of the eye, it can lead to permanent vision loss. The way you prevent that is 1, strict adherence to the 5 milligrams per kg per day, and 2, annual eye exams. Insurance, sometimes the United States will fight you on this. So if they do, you do a baseline eye exam, and you can start again according to the American Academy of Ophthalmology at 5 years, annual from there. Prognosis and monitoring, very simply, remember there's a low risk of progression. It varies by the subtype. When you see these patients, ask them 4 questions, and you'll capture whether or not they've evolved into SLE. Question 1, arthritis, joint pains. Question 2, sicca symptoms, dry eyes, dry mouth. Question 3, fatigue. And question 4, oral ulcers. You ask those, and you will capture the lion's share of patients with active SLE. Thank you so much.